Hello and welcome to this learning module. This session will cover multi-system trauma. This video is intended to supplement any readings or coursework assigned by your instructor. Upon successful completion of this learning module, students will be better able to describe the concept of the golden hour, define and list common causes of multi-system trauma, and differentiate the levels of trauma center capabilities. The term multisystem trauma describes patients who have experienced multiple traumatic injuries involving more than one organ system. Patients with multisystem trauma have a higher incidence of morbidity and mortality. This may include any combination of injuries such as head and spinal trauma, chest and abdominal trauma, or chest and musculoskeletal trauma. Research shows that the best chances of survival for multisystem and other seriously injured trauma patients happen when assessment, intervention, and transport take place as quickly as possible. The concept of the golden hour of trauma is a theoretical one that suggests that for the best patient outcome, they should arrive at a trauma center within 60 minutes of sustaining their injury. The golden hour model assumes that it takes 20 minutes from injury until EMS arrives on scene. Once on scene, our goal is to limit our on-scene time to 10 minutes or less. The remaining 30 minutes of the golden hour includes transport to a trauma center and, ideally, delivering the patient to the operating room if needed. One of the ways we can meet the demands of the golden hour is to utilize air medical transport for our sickest patients. We will talk in greater detail about the use of air medical transport in a video later in your course. Let's review some mechanisms that can lead to multi-system trauma. During a frontal impact, the occupant travels at the same speed as the vehicle. When the collision occurs, that energy is transferred to the vehicle and its occupants. Today's vehicles are designed to collapse and absorb the energy from a crash to minimize energy transfer to the occupants. As we evaluate the damage at a crash scene with a frontal pattern, keep in mind that these vehicles may appear heavily damaged, but were designed to crumple. Victims of a frontal collision may have head, chest, abdominal, and cervical injuries. While seatbelts and airbags are effective in preventing the second collision of the occupant against the vehicle interior, patients may still sustain significant internal injuries because of the collision of the organs in the body. Additionally, abrasions to the forearms and blunt facial trauma can happen from airbag deployment. Remember to inspect the interior of the vehicle for indications of points of patient contact, including the steering wheel, dashboard, and windshield. With lateral or side collisions, there can be injuries to about any part of the body. Much of this depends upon whether the patient was wearing a seatbelt, whether the vehicle had side impact airbags, and how much intrusion there is into the occupant's compartment. These types of crashes are also called T-bone crashes. Patients who experienced a lateral impact are prone to head and neck injuries, upper and lower extremity injury, and thoracic trauma. These types of collisions may require a rescue team to remove the door to access a victim who was located on the damaged side of the vehicle. Rollover crashes can cause significant injury to the patient, particularly if they were not wearing their seatbelt. These patients are at risk of being partially or completely ejected from the vehicle. With partial ejections, the vehicle tends to roll over the victim. Patients who were partially or fully ejected from the vehicle are prone to significant multi-system trauma and tend to have high mortality rates. In rollover crashes, where a patient was properly restrained and nothing in the vehicle struck the patient as it rolled, they will often self-extricate and may be ambulatory at the scene when EMS arrives. Careful assessment is required as the amount of adrenaline circulating in their body will be elevated and they may not realize they are injured. It's exceedingly difficult to predict injury patterns with rotational crashes. If an occupant was not properly restrained, there is always the possibility they could be partially or completely ejected during a rotational accident. Because of the unpredictable nature of a rotational crash, multi-system trauma is common. When we respond to pedestrian struck calls, the extent of damage to the patient is dependent upon several variables, including the vehicle speed, where the patient was hit on their body, how far they were thrown, and what the surface was that they landed on. It's important for us to determine whether the patient went up and over the vehicle, down and under the vehicle, or was thrown away from the vehicle. If possible, we also want to determine what part of their body hit the ground first. Obtaining information from bystanders will be extremely helpful as we attempt to determine the mechanism of injury. Injury patterns differ between adults and children. An adult will usually attempt to turn away from an oncoming vehicle, while a child will freeze and take the hit head on. Also, a passenger car will likely hit an adult's legs, while a school-aged child will be struck in the chest or abdomen. Larger vehicles like sport utility vehicles and pickup trucks will strike their victims higher up, which can cause significant head trauma to pediatric patients. Motorcycle collisions can cause significant trauma, especially if the rider was not wearing appropriate protective gear. By questioning bystanders at the scene, we may be able to get a good picture of what the impact looked like and how the rider was thrown from the bike. Even a controlled crash involving an experienced rider who laid the bike down can result in abrasions and possibly burns if the bike lands on top of them. The severity of injury sustained from a fall is dependent upon the distance the patient fell. In an adult, a fall of greater than 20 feet is considered significant. When we talk about pediatric falls, a fall of greater than 10 feet or 2 to 3 times the child's height is considered a significant mechanism of injury that may lead to multisystem trauma. Injury severity from falls is also going to depend on the surface the victim landed on and which part of the body impacted first. When a patient lands on their feet, the energy is transmitted to the spine, producing a spinal injury in addition to injuries to the legs and pelvis. If the horse rider in the bottom image landed on their arms, the energy could travel up their arms and into the shoulder. If they landed on their head, compression fractures of the vertebrae could happen. Blast injuries can result from explosions. There are 4 distinct phases of blast injury, and each phase can cause specific types of injury. If you look closely at the picture on the top, you can see the pressure wave pushing out from the blast site. This pressure wave can cause significant trauma, especially to hollow organs in the body. The graphic at the bottom shows the 4 types of blast injury. The primary injury occurs because of the pressure wave. Hollow organs such as ears, lungs, and stomach are particularly susceptible to damage from pressure waves. The brain is also susceptible to blast-induced traumatic brain injury. A secondary blast injury is caused by debris that is thrown from the force of the blast. Tertiary injury is caused by the victim being thrown to the ground or into an object. Lastly, quaternary injuries are collateral injuries resulting from structural collapse, hazardous materials, or heat dispersed from the blast. This slide lists the 4 levels of trauma centers as designated by the American College of Surgeons. A Level 1 trauma center has 24-hour in-house coverage by general surgeons and prompt availability of specialties such as orthopedics, neurosurgery, anesthesiology, and a host of other specialties. Level 1 trauma centers are affiliated with medical schools because they must engage in trauma research. A Level 2 trauma center can initiate definitive care for all injured patients. They have 24-hour immediate coverage by general surgeons as well as coverage by orthopedics, neurology, anesthesiology, emergency medicine, radiology, and critical care. A Level 3 trauma center has 24-hour immediate coverage by emergency medicine physicians and prompt availability of general surgeons and anesthesiology. Level 3 trauma centers are required to have transfer agreements for patients requiring more comprehensive care with either a Level 1 or Level 2 trauma center. Level 4 trauma centers are emergency departments that can implement advanced trauma life support protocols and have 24-hour lab coverage. Many of our local emergency departments meet this criterion. This map from the South Carolina Department of Public Health website illustrates the locations of the designated adult and pediatric trauma facilities throughout the state as of January 24th of 2024. It is important that you know what facilities are available in your region. Here we see the 2021 National Guidelines for the Field Triage of Injured Patients that were developed by the American College of Surgeons. Patients meeting any of the red criteria should be transported to the highest level trauma center available. Red patients with an unstable airway, severe shock, or traumatic arrest may require transport to the closest hospital for initial stabilization. Once stabilized, the patient can be transferred to a Level 1 or 2 trauma center for definitive care. Pediatric patients meeting the red criteria should be triaged to pediatric capable trauma centers when available. Patients who do not meet any red criteria but do meet any of the yellow criteria should preferably be transported to a trauma center. This does not need to be the highest level trauma center. The EMS judgment criteria should be considered in the context of resources available in the regional trauma system, including consultation of online medical control for further direction. Examples of patients with special, high-resource healthcare needs include tracheostomy with ventilator dependence and cardiac assist devices, among others. Patients with combined burns and trauma should be preferentially transported to a trauma center with burn care capability. If not available, then a trauma center takes precedence over a burn center. Specific age used to define children is based on local system resources and practice patterns. Please take a moment to pause your video and review the criteria presented on this slide. This brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, consider going back to review any content that you struggled with. Thank you for watching this learning video.